On phone,
Is
yeah.
live now. Stream is live.
Okay. Namaskar, salam, sat Sri Akal, very warm good evening to all of you. Friends, I am Dr. Seema Pandey, an infertility and IVF specialist from Azamgarh. And today I have special guest apart from V4 and she will introduce herself. She is a name and she decides what is best for that particular disease. She has gone to that situation. Yeah. So today we are going to talk about some newer innovations, friends. Like every day we keep talking about that things are moving fast in field of walk of life. Similarly, in medical science, especially gynecology and obstetrics, we have a not new, but relatively newer kid on the block, that is robotic surgery. Today, I have an expert who expertises in a single disease called endometriosis, and she is a surgeon par excellence, be it robotic, endoscopic, or anything. She'll join us within few minutes. Till then, here I am with my best friends, Dr. Anuradha Khar, Dr. Arshit Bal, and Dr. Raj Lakshmi Valavalkar. And welcome you all to this show. And Anu, let's keep ball moving, rolling. And I just wanted to ask Raj that what is her opinion regarding this uh, um, uh, evolvement of robotic surgery, and is it practically useful for our gynecology patients?
Okay, so basically, the science freak in me really loves the concept that we have a robot to work with now, because yes, in hands of a very good laparoscopic surgeon, you can get very good outcomes. But the robot actually allows you the fineness of movement and allows you to get into those smaller crevices. The robot is much nicer for like the surgeon's shoulder girdle and the surgeon's back. And obviously, it's sitting at the console, it's like playing a video game. Um, as a surgeon and as a science freak, I completely love it. Um, um, you know, um, Traditional laparoscopic surgeons always say laparoscopy kaha bura hai, robotic ki zarurat kya hai. But once you've seen a robotic surgery in action, and then you compare that with your normal surgery, you realize the wide difference in outcome that you give the patient. And Vimi just joined us. So Seema, if you can just introduce Vimi so I can ask her my first question actually. I'm dying to ask
Yes,
her.
yes, yes. And plus, welcome to Dr. Seema Pandey's talk show, Knowledge Shot, Dr. Vimebindra Basu. As I told you, she is one of the very good friend, like a younger sister. Apart from that, she'll introduce herself. And I'll also introduce my co-moderator, Dr. Anuradha Khan. She'll take over from here to question Vimi as I am in between traveling.
Dr. Vimi, please introduce yourself.
Hi everyone, and thank you, Dr. Seema, thank you, Dr. Anuradha, Dr. Arshi, and Dr. Raj Lakshmi for having me here today. I am a robotic and laparoscopic surgeon, and I am also a SRC accredited endometriosis surgeon at Apollo Hospitals, Hyderabad. And I'm also the founder of Endometriosis Foundation of India. So we have a multidisciplinary team to manage endometriosis at different locations. We have all kind of surgeons in our team, a colorectal surgeon, neurosurgeon, and if required, a cardiothoracic surgeon also for rheumatic and lung endometriosis. And thank you for having me here for today's discussion on robotic surgeries for gynecology diseases.
Vimli, it is absolutely our pleasure to have you here. I'm going to start with my question basically. You are already an accomplished minimal access laparoscopic surgeon. And then you also went over to start doing robotic surgery. So, in your opinion, which is your first love and which you like better currently?
My first love was always laparoscopic surgery. I started with the minimal invasive surgery, and I know my skill set, and I know I'm a good laparoscopic surgeon. So I was never hooked toward robotic surgery. I'll tell a little story behind it, how I became a robotic surgeon. So there, my colleagues are there, Dr. Sanjay Adla and Dr. Saeed Aina. She's a gynae oncologist, and Sanjay Adla is a neurosurgeon. And he's a robotic surgeon primarily. So every time he comes to laparoscopy theater of mine, and he used to say that you can do laparoscopy so well. Why don't you try robotic also? So for almost 2 years, they kept pushing me, and then finally I decided one day, okay, let me just train myself and see how it works. Then I got myself trained with the intuitive surgicals and started doing robotic surgery. And now it's not that I don't love laparoscopy, but then definitely robotic has become my passion. And once you do it, you realize that it is different. Patients, when I talk to them, they ask me like, what is the difference? So as people prefer iPhone over Android, it's the technology. It's until unless you use it, you don't get the hang of it. The difficult, complex cases, within the difficult areas is so easy with robotic surgery, because with complex endometriosis cases, what we do, the rectovaginal nodules, the ureteric involvement, the bladder endometriosis, bowel shaving, it's wonderful. It's fantastic. It's not that I cannot do this laparoscopically, but the effort we put in laparoscopy is much more what we put in robotically when we do these cases. That I have realized after doing it. Till I was not doing it, I was very adamant and very against robotic, you may say, maybe 2 years back. But now, after doing, I have realized it definitely has an edge over laparoscopy surgery for complex cases. Definitely not for simple hysterectomies or very simple cystectomies and all. Definitely, it does not have an edge. It increases the cost for the patient also. So, for selective cases, frozen pelvis, complex cases, tubal recanalization, Birch colposuspension, sacrocolpopexy, this is very, very good.
Thank you so
Thank you,
much.
Dr. Vimi, and a warm welcome to you. My question is, my point is that what is this robo? People who have not seen the theater where operation theaters where robotic counsel and all that are there, for them, it looks like it's a robo going and operating the kind of robos we see in movies. So can you tell us what are the four important components of your robotic surgery, so that you can smoothly do it? What are the four important components of your?
A very good question, Dr. Anuradha, because many a times when we offer our patients robotic surgery, the first thing they say, no, doctor, I want you to do the surgery. So they have an impression that a robot goes there and does the surgery. So first of all, I would like to clarify there is no robot who does the surgery. It is your surgeon only who does the surgery. But definitely there is a different instrumental arrangement which is there for robotic surgeries. We have main three components which are involved in robotic surgery. One is the surgeon's console. Surgeon's console is a place where you have all the controls. Your surgeon sits there, and it surgeon can control your camera, your instruments, cautery, everything can be controlled from the surgeon's console. Second is the vision card, from where you can see the surgery and operate. Third is the patient card. The patient card is something which is brought to the patient, and we that is basically we call it docking of the robo. So that the patient card is brought to the patient side, and like in laparoscopy, we put 3-4 holes. Similarly, we put 3-4 holes in robotic surgery, and this patient card has docks which we dock it onto the ports, which the robotic instruments are inserted, and this complete control is under the surgeon. So surgeon is also not dependent too much on the assistants. In laparoscopy, a lot of dependence is on the assistant. If the camera is held by an assistant, if you don't, because my assistant who shows me the camera are my eyes, I cannot operate if they don't show me properly. So that control is little less in laparoscopy, but in robotic, everything is under surgeon's control, and it is very safe. There is no problem with the robotic system. The feedback mechanism of the robo, suppose any fault happens or anything happens, it immediately shuts down. The patient safety is a priority in a robotic system, and it has a wonderful feedback mechanism where if my bipolar is not working, if my Caesar is faulty, immediately it shows me on the screen that there is some problem. So it is, I would say, it is much, much better than laparoscopy, because laparoscopy does not have these commands. If the instrument is not working, I have to identify that it is not working. But here, this robotic system gives me the signals that this is not working, change it, swap it, or do something else, or I'm using the wrong this thing. So this is a very well calculated AI powered device, which helps surgeons in performing these surgeries in a much, much better way.
So I'll summarize for our viewers that a robotic surgery is done with the help of a surgeon's console, the patient side cart, and there are robotic arms. Then, most important, there's a high definition 3D vision system, which definitely has an advantage over the 2D because of the depth. So, these are the major components. And for our viewers, we want to say that it's extremely safe to do robotic and because your surgeon is operating. So, Dr. Seema, over to you.
I have one question, just relevant with this. Dr. Vimmi, then why there is a lag period, like this robotic surgery came into action some 10 years back, but still in this time there's a quite a big lag. Why it has not developed? Why people were not comfortable in it? What was the basic reason for not getting it accepted as the time has passed? Very few surgeons are there still.
One is, I would say, cost to the patient. The cost, yes, I still agree that significantly increases as compared to laparoscopy, because robotic system is much, much costlier than laparoscopic systems. Then whatever instruments we use in robotic system, each time we use it, there is a consumable cost to that.
Okay.
So there comes the difference when we compare it to laparoscopy. If finances are not a cost, finances are not an issue for every case, I will choose a robotic now.
So these are covered under insurance, robotic surgery, or is it not covered?
It is
Our
covered.
company.
It is covered by some insurances. Some insurances
Okay.
don't cover. Now that is again a big fight. Suppose I do a hysterectomy. Now there are some insurances, the national insurances like the national insurance, the Medi Assist, and some other 2-3 government insurance, Star Health and all. They have this hysterectomy listed as a GIPSA package with the hospital. Now GIPSA package is a fixed package, like around 90,000 they pay to the hospital, and it includes everything.
Okay.
Now, when we do surgery in a hysterectomy in an open billing, it comes around 2.5 lakh or 2.7 lakh. As compared to laparoscopic surgery, also the hospital and the doctor both gets less paid. Now, suppose I send to this insurance a robotic hysterectomy. They say this hysterectomy surgery is listed under GIPSA. We cannot approve it.
Okay.
But there are some insurances like HDFC Care and some other insurances which are private insurances. They have open billing system, and if we write robotic hysterectomy, they approve. So there
Okay.
comes
So
the difference where different tie-ups or different third-party involvement for insurance companies rejects the insurance claim. But
because
as
this is very important part regarding the finances, because in our country most of the patients they are backed because of these financial issues only. So
yes,
that's why I took
and
this
the
question.
patient aspect. Now,
There
if we
is
come to the doctor aspect, now every hospital doesn't have a robo. So one is, even if you don't want to do it, you cannot do it. Sometimes the corporate hospitals who own a robo, they do not allow a visiting surgeons because they have only one robo and their in-house consultants will not get the robotic system. So
Okay.
there are many surgeons who want to transition from laparoscopy to robotic, but still they're not able to do it because of the accessibility, and they have small private centers where they do laparoscopically and every surgery, but they cannot afford to keep a robo separately in a standalone center.
Dr.
Second,
Vimmi.
hmm,
Yes, please complete first.
and one more aspect is, if you see many surgeons, who do not want to do the laparoscopy. Like from open to laparoscopy, there was a controversy. From laparoscopy to robotic, there is always a controversy. I was also in that category few years back. So these all three factors are there which are contributory. But now there are four robotic systems available at present in India, like CMR Robo is there, Mantra is there, the Indian version, Hugo Ras is there, and DaVinci XI is there. We have DaVinci XI. Now, with so many systems coming up, definitely the cost is coming down now, and patient acceptability is increasing. Now, patients want the robotic surgery. They come and tell us that I want a robotic surgery, I want a laparoscopic surgery. So, this is more about awareness, accessibility, financial affordability, and the skill set of the surgeons as well.
Yeah.
So, Vinny,
Dr. Seema.
here I would just intervene from a medical point of view, who has just finished his post or her post graduation, and she wants to be a surgeon. And here is the dilemma: if you like conclude, given a choice, as you said that you have really it seems fallen in love with the technique, and you would choose to do everything through robotics, but given a choice of robotics and laparoscopy with 3D camera, what are the cases which you exclusively would like to do through laparoscope, and what are the things which you would like that should be must to be done as through your robotics? First thing. Second thing, how it seems that there is a long learning curve. Is a robotic surgeon has to be a laparoscopic surgeon first, according to me? Obviously, otherwise how is he going or she going to move everything, or she can directly go to robotics without learning and the endoscopic surgeries, laparoscopic surgeries. And third thing, if it is so comfortable, cost, forget about the cost for particular set of people who are doing really, really well in this field, even they are not switching over to robotics. So, what is the message a simple postgraduate should be getting if he had a neutral mind regarding choosing for further training or advancing his or her skills?
So, first question you asked me, like, what are the indications where robotic should be there? See, I cannot say that this is must for this surgery. Robotic should be used because everybody doesn't have robotic system, definitely. But there are certain indications where robotic definitely will give better outcomes and better results, like complex endometriosis cases, frozen pelvis, ureteric endometriosis, ureteric reimplantations, diaphragmatic endometriosis, endometriosis of parametrium and pelvic nerves, where we explore sciatic nerve, go deep down, rectovaginal nodules. These cases, it has an excellent edge over laparoscopy.
I'm
Now,
just interrupting again. Being an endometriotic surgeon and switching over from laparoscopy to advancing to robotic surgery, how much improvement did you see in this growth curve, learning curve, and result, ultimate result in your surgical outcome for the patient?
I would say there is a huge improvement because the dissection which we do with robotic in such deeper and far reaching areas where straight instruments do not reach is much, much better. In laparoscopy, reaching up to the sciatic nerve is very, very difficult. It's not impossible, definitely, but it is very difficult, which you can do it with much ease with robotic system. So when you can do with much ease, there is less manipulation of the tissue, less bleeding, less nerve damage, neuropraxia is less. Definitely, post-operative outcomes are better. So these patients have less morbidity, less post-operative minor side effects, which we usually sometimes, if we take a questionnaire and ask the patients, definitely we can make out a difference. Which on an average, if you ask the patient in 1 week, you will recover. Both the patients will recover in 1 week to 10 days. But the minor symptoms and signs, which are major issues with the parametrial and sciatic nerve endometriosis, they are much, much lesser with the robotic access.
So it is like iatrogenic complications are less.
Yes, we can say that. These are minor complications. Patients will not have any long term issues with that. but definitely it has a huge impact on the recovery and the outcomes.
See, I have a question because we are infertility specialists. So, what about myomectomy? Because what is said, what is written in literature is that the larger myomas are difficult to take out by robotic surgery because visualization is a bit of problem when there are large myomas. Is that true? I read somewhere.
I don't think so. See,
How
there
big
is,
myomas? Up to what
we have
size
done
you
even
can?
20, 25 centimeter also.
I
So
think this would be
probably,
the beauty. This would be the beauty because robot doesn't have eyes. It goes according to the programming, so that bigger myoma will robotic will be should be beneficial according to me. I don't know.
It's all
Yeah,
depends how you place your ports. Now in
yeah.
laparoscopy, once you have placed the ports, you can change them. You can change the direction, or if you want, okay, no, I have placed a port much lower down and I have to change it. But in robotic system, we have to be very careful with the port placement, because once the docking is done, it is a waste of time, waste of money as well, and increasing the operative time if we keep on changing the docking system. It's not that it cannot be done, but that should not be practiced. So first step when we teach robotic surgery to our upcoming surgeons is that they should be well versed with the port placement and the docking as compared to laparoscopy. This is a very, very important point. Now, port placement, the primary port should be at least 15 to 20 centimeter from the target organ. So if you do that and you go much higher up, 20, 25 centimeter fibroid also is not a big deal. Now, as compared to laparoscopy, here I would like to mention that in robotically, suturing is much efficient and better. Those who are not a good laparoscopic suturing surgeons, those who find it difficult to suture, definitely robotic has an edge. If you are good at suturing in
Also,
laparoscopy, not an issue. You can
yeah.
do myomectomies also very well. But in robotic, if you find yourself you're struggling with the suturing, robotic suturing is much easier. One more important indication which I forgot to mention in the previous point, that adenomyomectomy surgery. It's a very good suturing in robotic this thing, because adenomyotic tissue is very hard. It's not as myomectomies. So as compared to myomectomy, if you ask me, adenomyomectomy has a better outcome and better surgical experience in robotic as compared to laparoscopy, because it suturing is an art, we always say, but in adenomyomectomy, suturing is a different skill set. It is not as easy as myomectomies.
So, Dr. Vimi, what we gather from what you said is the visualization of the anatomical layers is better. So, it is very efficiently you can suture via the robotic surgeon can suture it better. And secondly, because of the council, the wrist movements are much more freer and the angles are better, like 360-degree kind of a
It has
movement.
220-degree range of motion and
Yeah,
3D motion is there,
yeah.
and
So
7
the
degrees
wrist
of movement.
movements, yeah, wrist movements in robotic are much more freer than what they are in the laparoscopy, right?
Definitely.
So that makes the difference in suturing and it becomes a little easier. Yeah.
Yes.
so Dr. Vimni, you please answer the first part, the one which Seema has asked for new upcoming
New
uh,
part.
student. Yeah, that also.
So coming to the second part, Dr. Seema asked me that beginners, what do we advise that you become a direct robotic surgeon? So there is a problem if they become a direct robotic surgeon. So if they become a direct robotic surgeon, they will end up opening every case if they fail to do a robotic surgery. So first learn laparoscopic surgery before you go for robotic surgery. Robot is also an instrument. It suppose it is faulty, it is not working. You can use the same ports and do a laparoscopic surgery and finish your surgery. So never go for robotic surgery directly. If you have learned open surgeries, go for laparoscopic surgery training. Get well versed with all types of surgery. Then transition yourself to robotic surgery. There is learning curve for laparoscopy is little longer. I agree, but it's not that you don't know the laparoscopic principles and techniques, and robotic surgery will become in robotic surgery will become in 1 or 2 days. It's not like that. I picked up fast because I was very well versed with laparoscopic surgeries of all kinds. But suppose robotic system fails, what will you do? You'll end up opening the patient. So that is another increasing the morbidity for the patient. So never do that, that you become direct a robotic surgeon. You should know laparoscopic surgery, then only you become a robotic surgeon. Without that, nobody should do directly robotic surgery.
Reason I ask this question nowadays, the looking at the trend, the moment when your kid is in class 8th or 7th, he or she starts preparing from pre-medical exam. The moment they enter in medical college, they start preparing for post graduation starting from first year, and by the time they finish their post graduation, they have set up their mind, I have to do fetal medicine, I have to do endoscopy, I have to do this and that. And for them, I wanted to send this message that your basics are really important. If your basics are strong, then only you can build up something stronger. And that was the thing, that's why I wanted to ask you, मेरे हिंदी दर्शकों के लिए जो तब से सोच रहे हैं ये रोबोटिक्स में क्या चल रहा है, मैं बता दूं दोस्तों कि ये एक ऑपरेशन करने की, पेट से सर्जरी करने की एक लेटेस्ट विधि है। आप रोबोट्स का नाम सुना होगा आपने, जैसा अनुराधा जी ने कहा, ये वैसे नहीं हो सकता है कि रोबोट चलता हुआ आएगा, आपके पेट में छुरा डाल देगा और ऑपरेट करेगा। रोबोटिक सर्जरी एंडोस्कोपिक सर्जरी की एक और एडवांसमेंट है, स्टेज है, जहाँ पे आपका सर्जन बिना थके एक जगह पे बैठ के एक बार सिस्टम आपके ऊपर सेट कर लेता है, तो वहां से बैठ करके वो विभिन्न विभिन्न प्रकार की कठिन से कठिन ऑपरेशंस को सफलता पूर्वक अंजाम दे सकता है। और उन जगहों पे जहाँ पे जाने में आपको नॉर्मल आईज और लैप्रोस्कोपी के थ्रू दिक्कत होती है, उन सब जगहों पे आपकी रोबोटिक आई पहुंच जाती है और उनका डिसेक्शन और रिकवरी पीरियड, जैसे जब पेट खोल के सर्जरी होती थी तो उसमें जितना टाइम रिकवरी में लगता था उससे कम लैप्रोस्कोपी में हुआ, अब बहुत ज़्यादा कम। और डिफिकल्टीज, पेन, पोस्ट ऑपरेटिव नौशिया, वॉमिटिंग, जो भी प्रॉब्लम्स आती हैं वो सब बहुत कम हो जाती हैं। ओनली लिमिटेशन इज कि इंश्योरेंस कंपनीज इसको इंडिया में उतना ज़्यादा सपोर्ट नहीं करती हैं, और ये बहुत एक्सपेंसिव प्रोसेस है। हर डॉक्टर के पास ये होता नहीं है, हर हॉस्पिटल में नहीं होता है। लेकिन कुछ बीमारियां जैसे एंडोमेट्रियोसिस स्टेज 3-4 डीप एंडोमेट्रियोसिस, जैसा डॉक्टर विमे बिंद्रा बासु ने बताया कि ये जगह हैं जहाँ पे आपको एडेनोमायोमा है, आजकल एडेनोमायोसिस मैं आपको बार बार बताती रहती हूँ, उन सब जगहों पे अगर रोबोटिक्स का इस्तेमाल किया जाए तो आपके सर्जिकल आउटकम्स बेटर होता है। तो डॉक्टर अनु, 3 shots you start today.
Dr. Mimi, I have last question. What is the average time taken if you compare a conventional laparoscopic surgery, say hysterectomy, vis-a-vis robotic? Is robotic surgery more time consuming or is it shorter?
It's same. It's not time consuming, because earlier the robotic system which was there it used to take a little while for docking. So
Yeah.
everybody considers that docking takes a lot of time. इसके लिए भी half of the surgeons don't want to get trained. But now with Da Vinci XI and the newer systems, docking is just 5 minutes. You just put in your ports, get the patient card, dock it, start the surgery. So there is no hassle. It's hassle-free surgery. Doesn't take much time. It all depends on your team, how well trained they are and how well coordinated they are. So there is no difference in time taken for robotic surgeries. It's same.
So
मैं यहाँ पे
we
एक चीज ऐड करना चाहूंगी, सीमा मैडम ने, डॉक्टर सीमा ने जो बोला, दर्शकों के लिए, बहुत सारे दर्शक ये कहेंगे कि पहले रोबोटिक सर्जरी नहीं होती थी तो क्या बीमारियां नहीं होती थी? पहले भी एंडोमेट्रोसिस होता था और ये ज्यादातर ट्रीट नहीं हो पाता था, और बहुत सारी महिलाएं इसमें हिस्टेक्टमी करा पाती थी और उनको ट्रीट नहीं होने की वजह से इनफर्टिलिटी का ट्रीटमेंट भी नहीं मिल पाता था, या वो कंसीव नहीं कर पाती थी थ्रू वेरियस प्रोसीजर्स लाइक आईवीएफ, और ये क्योंकि उनको सही ट्रीट नहीं कर पाते थे, उस लेवल के एंडोमेट्रोसिस को ऑपरेट नहीं हो पाता था प्रॉपरली। और विद रोबोटिक सर्जरी दीज ऑल थिंग्स विच आर ऑलरेडी देयर इन पास्ट, पहले भी थी ये बीमारियां, पर अब ये पूरी तरह से ऑपरेट हो पाती हैं और इनके रिजल्ट्स जो होते हैं एक आम महिला के लिए बहुत अच्छे हो जाते हैं। और उसके जो फर्दर जो ट्रीटमेंट जो चाहिए होता है, जैसे इनफर्टिलिटी है तो आगे उसको आईवीएफ चाहिए, तो वो सारी चीजें पॉसिबल बहुत इजीली हो जाती हैं। तो था पहले भी बीमारी, पर अब उसके नए तकनीक के आने से इलाज आसान हो गया है.
So let's start with three shots from Dr. Vimi Bindra.
Oh,
Yes,
yeah.
Anu.
I have to say, or Vimi?
Let's start with our guest first.
Yeah, Dr.
Three
Vimi.
knowledge shot you have to give.
3 shots, 3 points, takeaway
Three
points.
takeaway points.
We
The
call
robotic
it.
surgery is not done by a robo, it is done by your surgeon. Uh, choose your
This
surgeon wisely.
program, Dr. Vimi, this program is for medicos as well. It's not like my previous show, not only for patients. So, a lot of doctors are logged in too.
That's good to know. And as we discussed, Dr. Seema and Dr. Arshi, Dr. Anuradha, everybody said that basics are very, very important. So keep a hold on your basics and then go for the advanced training. And definitely, once you start doing this surgery, you can strategize and choose your cases wisely. Just such a simple normal hysterectomy, don't choose robotic surgery, definitely. But then complex cases where patient will get benefited, better outcomes, robotic surgery is always better than laparoscopic surgery.
Okay, my 3 shots. Robotics has
Yes.
an edge over conventional laparoscopy with regards to complex surgeries. Number 1 point. Second, there is less morbidity, less pain with robotic surgeries. Third, suturing is comparatively easier with robotic arms rather than the conventional laparoscope.
So
Yes,
I will
Dr.
go
Arshi.
with a good setup. A very nice setup should be very important in as far as the system is concerned, not about the building. It should, the infrastructure should be very meticulously judged and installed. The skills should be fine. You should give a right time for the learning curve and the right decision for the patient, because it is robotic surgery and the patient is investing a lot.
So, thank you so much for your valuable shots, dear friends. Here ends our today's knowledge short Dr. Seema Pandey's talk show. We'll meet tomorrow again. Before that, I would like to thank our guests and dear friend Dr. Vimi Bindra to join us at such a short notice. Friends, nowadays we just give 4 or 5 hours notice to our friends and we just आपकी अदालत में हाजिर टाइप्स उन्हें बुला लेते हैं. But they are, look at their knowledge, how thorough they are, that they don't mind coming and talking impromptu. I would like to thank my friends Dr. Anuradha Khar, Dr. Arshik Bal, Dr. Rajlakshmi Balavalkar is not here, and a very lovely good evening, good night from all four of us to all of you. Thank you so much.
Thank you
I
so
have
much.
request to all our
Thank you for
speakers.
having me, and it was a great pleasure to be here. Thank you so much.
Thank you, Dr. Vimi, and thank you, everyone. I would like to tell my Isarians that we are contesting for the Dr. Seema is contesting for the post of librarian, honorary librarian, and I'm contesting for the post of member managing committee of ISAR clinician. The voting starts on 11th of January. Your vote is valuable, and kindly consider us for your vote. Thank you so much.
I too request everybody to please vote and support my dear friends, Dr. Seema Pandey, Dr. Anuradha Kar. Let them win with a huge number of votes and make them successful and be the leader as an SRN. Thank you so much.
They can be the best leaders, I would say, and choose your
Yes,
leaders also wisely and vote them, support them, and they will definitely work for the organization and they'll represent us. Thank you.
Thank you so much.
thank you
Thank you
so
so
much.
much, dear friends. Till we meet again tomorrow. Bye bye. Good night. Shabba khair.